And good to see you, Cynthia. I see names coming up today or this afternoon. Good to see you, Neoma, Laura, and I think John. There's actually a couple of Johns on here this afternoon, and Elena or Alana. I'm sorry if I'm mispronouncing anybody's name.
All right.
It's good to see you, Nancy, as well. And I see a couple of hand raised. We'll get to some of those. Good to see you, Camille.
All right, Deanna, my screen is shared. Can you see the PowerPoint there?
Yes, we can.
All right, and we are live, and I think we can get rolling whenever you are ready.
All right, well, good afternoon. Thank you for your time and attention as we are here this evening to discuss the Reimagining Public Safety Collaborative Plan regarding an alternative response involving crisis intervention services. We thank you all for your time and attention today. This Reimagining Public Safety Collaborative belongs to all of us. There's no role in the community where this does not touch or impact the work that each of you do. So we thank you for your time and attention again this evening. My name is Deanna Carruthers, and I'm the Chief Equity and Diversity Officer for Tompkins County. And I appreciate the time of my colleagues this evening again who are taking time to share what they do every day. As we go through the Reimagining Public Safety process, this conversation is to level set about what our services look like. Again, no decisions have been made about the process, but we think it is important as an educational opportunity to inform those who are around us about the impact, potential impact of a service delivery change. And so I will turn it over to my colleagues to make introductions. Harmony, you're on mute.
Sorry about that. Good afternoon, everyone. My name is Harmony Ayers-Friedlander. I'm the Deputy Commissioner of the Mental Health Department and also the Director of Community Services. And I'm happy to be with you here today to talk about our mobile crisis team.
Hi, everybody. I'm Derek Osborne, Tompkins County Sheriff. Happy to be here. Thank you.
Chief Joly, you want to jump in here?
Sure. Hi, everyone. John Joly, the Acting Chief at Ithaca Police Department.
Good evening, everybody. My name is Michael Steitley. I'm the Director of the Department of Emergency Response, and I'm responsible for the County 911 system and the Department of Emergency Management.
Thank you. So this will be hopefully an informative 90 minutes of your time. This is the agenda that we'll go through on this afternoon. Again, the emphasis of our conversation this afternoon will be on provide an overview of the alternative response evaluation of the Reimagining Plan. Specifically, a lot of questions are, what is an alternative response? An alternative response could be anything. So for example, outside of our traditional law enforcement response. For example, we have the community outreach program. We have the LEAD program. There's Cahoots models out there. And so we want you to be able to open your mind in terms of opportunities that exist out there, but then also be creative, but also as we center public safety specific around minoritized community to make our entire community whole and safe. Again, we will focus on that particular plan, but then also as we share that information, people often ask the question, how does this work? And so we'll also, we'll start with the initial call, looking at dispatch calls for service. And so if someone calls 911 or they call into a public safety service, what does that look like? And then if police are dispatched, what does that look like? We'll actually go through the Tompkins County Sheriff's Office response in addition to the Ithaca Police Department. While they are both law enforcement agencies, they have separate jurisdictions, and there are sometimes where their responses might be similar or dissimilar based upon their protocols or their boundaries or their rules and regulations. Then from there, we will have you go through the current mental health response. We have our deputy mental health director here in terms of Harmony Ayers, who will actually communicate to us what the mental health response looks like. And then from there, based upon the information that we share with you this afternoon, we'll have a Q&A on what, if you have any questions about those things, but then also we are going to leave you with the charge in terms of 3 questions about what models we could pursue. What are some of the challenges you see with getting moving forward, but then also what are the ideas out there and what are the things we should be doing? So again, we appreciate your time and attention, and this is going to be one of 3 times you're going to hear me say this evening. We encourage all of you as we get the process started to go to the website, which is www.publicsafetyreimagined.org to create a profile and put your ideas there. We will listen to your comments on this afternoon and evening, but also anytime you have an idea that is discussed or have an idea that we may have not discussed, we want you to put that information there. And so I will turn this over to my colleague, Michael Stackley, to kick it off. And so again, thank you, Michael, as we get started.
Thank you, Deanna. I appreciate it. Dominic, could you advance to the next slide? So good evening, everybody. I'm really honored to be part of the process and to be here tonight to answer any questions you may have. What I did was I put together a slide that lays out the steps that occur when somebody if somebody calls 911. In the first part of the slide, you'll notice that the call is taken or received by a 911 dispatcher that typically in this position has a dual responsibility. They're the initial call taker, but often are also the individuals that have to dispatch a critical call for service, typically a medical emergency. That first dispatcher receives a call and triages the call and uses a variety of different 911 products, if you will, or tools to help them assess and triage that call. If a call is a medical related call, they'll ask very specific questions of the caller to try to ensure that they're dispatching the appropriate resources. And sometimes those resources could be a single agency such as EMS, or there could be a situation where a call would require the dispatcher to dispatch police, fire, and EMS all together, depending on the nature of the call. That first dispatcher will also spend time with the caller, even after they initially triage it, in order to get resources moving quickly to the caller's location. If it's a medical emergency that requires something referred to as pre-arrival instructions, those are instructions that the dispatcher is trained to give the caller to help them deal with the emergency until emergency first responders arrive. And again, that's more common in medical emergencies. Sometimes it could be assisting a person in delivery of a baby. It could be giving instructions on how to do CPR. But again, it's to make sure that the caller is able to help manage the emergency until first responders arrive. Sometimes that dispatcher will stay on the phone with the caller until those agencies arrive, because that type of call just might warrant that extra bit of care. However, if the caller and the dispatcher both feel comfortable that the emergency services are en route and that the caller can help with that emergency until those services arrive, then they will disconnect from the call. But again, it is on a case-by-case basis. The second dispatcher will often receive the information from the first dispatcher and then dispatch those appropriate resources. From there, the second or even third dispatcher, which isn't in the slide, but they'll monitor that call. And so the 911 center is involved with the call from the moment the call comes in through 911 until the emergency services units clear. Again, that could be police, fire, or EMS. But they'll stay in constant contact with those first responders so that if there's any new information that comes in through the 911 call, that they can relay that information to the first responders. But additionally, sometimes those first responders need another first responder agency to assist. So a good example of that is maybe a call comes in through the 911 center for a motor vehicle accident, and that might initially just seem like they need a law enforcement response. Perhaps maybe the caller doesn't know if there's any injuries, or we just don't have enough information yet to know if we need to dispatch EMS. Now, once law enforcement gets there, they might quickly assess the scene and say, oh, wow, we have a medical emergency here. We're going to need an ambulance. So they'll call back to the 911 center and speak with one of the dispatchers to request that emergency medical response. And the same thing can hold true for fire. So it's not uncommon for an emergency service first responder entity to arrive on scene and need the services of another first responder agency. So it's really our job to take that call, initially shepherd it through getting it to the first responder agency that's most appropriate based on the information we get from the caller, and then monitor that call until its conclusion. Thank you. And I look forward to questions if you have any at the end.
All right. Now we're going to move to our second. Again, If we think about this, so if someone calls in, Michael just described what happens when dispatch takes a call. So the next portion of this will be coming from law enforcement, sharing specifically what happens after that call is received and is dispatched. So what responses specifically around the sheriff's office and the Ithaca Police Department. So Derek and John, feel free.
All right, I can jump in and start at least, and Chief, you can jump in whenever you like. Yeah, currently, as we know, a lot of calls fall on law enforcement, and that's simply due to the fact that we're probably one of the only 24/7 working agencies able to respond to any calls. With us currently in our current state, we handle just about everything. We could handle a parking issue, a loud music complaint, and then respond to a call related to somebody suffering from a mental illness. Or we could respond to any different type of call that has a mental health component to it. We currently respond based on our jurisdictions. The sheriff's office has jurisdiction over the entire county, but we typically don't respond first to calls inside the city of Ithaca. That's left to the Ithaca Police Department, as well as villages that have their own police departments. Although we do jump in the villages when they don't have coverage, which often happens because they can't staff things 24/7. Chief, did you want to jump in? And
Sure. Yeah, I think, speaking for how IPD would respond, and I think Sheriff touched on a little bit is, sometimes we'll get a specific call, from the dispatch center where it's, a check the welfare type of a call with maybe there's some comments in there that either a family member of the complainant, or I'm sorry, of the individual, or, someone witnessed some behavior that they felt was, mental health related. And generally what ends up happening is we are dispatched to the call initially. So in those cases, the officers will send 2 officers generally to these calls, and they'll arrive on scene, kind of assess the situation. We may be familiar with the individual, may not. The officer will try to build rapport, and then try to see and assess if additional resources, from mental health would be appropriate or helpful in the situation. And then we would go ahead at that point. If we felt like we needed mental health assistance, we would reach out to whoever. If it's during business hours, we would reach out to mental health, or we'd reach out to the on-call person from mobile crisis after hours. Sometimes it's the same person. Then other times, often, we'll respond to a call. It could be a domestic or dispute, or just any general. It could be a theft complaint that ends up having a mental health component as well with it. And, those oftentimes is probably the more common way that we get involved with people in need of mental health assistance, I would say. And currently the response model is the officers just build rapport, do the best we can to de-escalate the situation and get the person to, generally it's usually to Cuga Medical for evaluation and assistance there. And that's done through a 941. Usually if the person is not necessarily willing to go on their own, sometimes even if they are, we'll fill it out, just to ensure that they get the appropriate evaluation at the hospital. Other ways that we can deal with these situations or get involved in these situations is it may be someone that mental health is aware of, and they'll fill out their own version 945 orders, which I think Harmony will talk about later. And then at that point, we will assist them with trying to ensure that the individual in need of mental health services is connected with those services and transported to the hospital. And oftentimes it involves Bang's ambulance as well for the transport. So I think it can happen a lot of different ways. It happens around the clock, as the sheriff said, many times it's after hours. And I think, currently our resources really are pretty limited as far as experts that can help us with this. Mental health has people that will assist us over the phone often, and sometimes it's very helpful. Other times it would be more helpful if we could have a resource that was available to respond out 24 hours a day, which hopefully we'll talk about as we continue the conversation. But I'm happy to take questions as we go through this as well, if I haven't covered something.
Thank you.
Yeah, and
John,
I
we're
can
gonna-
just,
Go ahead, Derek.
yeah, I can add just the last piece there. Currently, a lot of the relationships we've established over the years to help us with these types of calls happen after the fact, and that's the unfortunate part. A lot of times we will deal with somebody, we may have to 941 them to the hospital, like the chief said, or if they're not a danger to themselves at that point, we leave them be, and then we may have follow up with some of the agencies below if it's that are listed at the bottom of the slide. If it's not the mental health department, it could be the advocacy center or office of the aging to do a check-in on that person, things of that nature. So these are just relationships that we currently have, again, that we've established over the years, just getting to know who the people are that we can go to help us follow up with care of that individual.
Thank you. Thank you. So now that we've heard from law enforcement in terms of what are our traditional approaches, and so if someone calls and then right now law enforcement will go to the scene, is that a good way to describe it? John and Derek, if law enforcement may or may be there, depending upon what is happening, and then from there, they may call in a call for mental health support. Is that an accurate way to describe what that looks like? I'm just asking, so we're trying to take you on a journey in terms of the conversation. What happens with the call? Perfect.
Yes,
and so
yeah.
Thank you. And so from there, so then if law enforcement identifies that we need a mental health response, I'm going to turn it over to my colleague here, Harmony, to talk about what happens next.
Thanks, Deanna. So at first, I just want to give you a brief history and let you know a little bit about the mobile crisis team. So the team was started around 2018 and we received some grant funding in order to start it. And then it's continued since then. So it's still a pretty new team that's been created. It's composed of currently about 15 members of the mental health department who voluntarily sign up to provide on-call coverage in the evenings, nights, weekends, and holidays. So they are paid for that time, but they volunteer to sign up to work on those shifts. And they receive specialized training to be a member of the team, and they meet weekly as a team. The one exception to that model is that we have one daytime person who works on the mobile crisis team exclusively during the hours that we are open. That person responds to crises during the day, and they also do follow-up supports to people who have used the mobile crisis team, maybe in the middle of the night or something like that, to check in and to see if there's other supports we can offer them. I wanted to talk also a little bit about what a mental health crisis is, because I think we've all, probably experienced our own sort of emotional crisis or seen people when they're really distressed. And that's a little bit different than what a mental health crisis is. It's really something related. It's a crisis that's related to someone's mental illness. So it could look like a person being suicidal, or maybe even having some sort of thoughts about killing someone, homicidal, if it's related to their mental illness. A person could look really disoriented. They could really have a hard time making sense to the average person. They can be pretty out of control even, and have a hard time with understanding like the reality and the situation they're in the moment. So that's what a mental health crisis can look like, and it's really related to a part of their illness. What our mobile crisis team does is triage those situations, and what we're really looking at is sort of making the difference between, is this a crisis situation that we can build supports around in the community that can help this person stabilize right now? Or is this a person that, based on their presentation, it looks like they need care and treatment, or there's a high likelihood that there could be harm, either harm to themselves or harm to someone else in the public? And that can be a pretty hard standard to assess when you don't have a significant amount of time or history on the person. So one of the things that's helpful for our team is we have a mobile crisis team when it's not regular business hours, of 2 people: a primary, who's a clinically trained person, and a secondary who has a lot of clinical support experience. And so together they can address the crisis The primary person may be the one talking to the person in a crisis situation, while the secondary is opening a file, looking in our system to see if we've ever worked with that person before in our mobile crisis team or in our department somewhere. We serve almost 2,000 people in the community. So oftentimes we can get some history about that person that can help us in determining how best to respond. So that's pretty much that assessment. And we're trying to make that very clear decision as to, is this person able to be stabilized in the community, or do they really need an emergency response where they need to go to the hospital for further evaluation and potential hospitalization? And that's when the Mental Hygiene Law 945 transport order comes into play. So basically what that law says is that the mobile crisis team members are given the authority to write an order to say the person needs to be transported to the hospital if it's against their will. So much of the time we work with people to try and help them if they need to go to the hospital. Maybe a family member or a friend can transport them and it's decided that that's safe to do. But there are sometimes people are really in the throes of their mental illness and they don't really have that ability to make a safe decision and to really recognize the need for healthcare at that point. And so we work closely with law enforcement around that. We often try and use the ambulance to help with that transport whenever possible. Sometimes law enforcement actually rides in the ambulance with the person so that we can make sure it's safe. So that's what a 945 order is used for. Next slide. I just wanted to show this to you because this comes out of the Office of Mental Health, and our mobile crisis team is under the regulatory guidance of the Office of Mental Health in New York State. And this is sort of the vision they have. And we don't have all the pieces currently in our system, but I just wanted you to be aware that here, like a person's in crisis, they have access to a crisis line where 80% of crisis calls can be resolved via the telephone. And then of that remaining 20%, 70% are responded to by a mobile crisis team. And you can see below that van that they show for the mobile crisis team, there's also a law enforcement because there's always this coordination and support, because sometimes people do need a 945, or there may be, the situation can be tense if this person, is violent because of their mental illness. Having that law enforcement support is important as well. And then Office of Mental Health really wants to see more crisis facilities. They've done some work in other communities where they've built crisis facilities. They're able to support people. It's higher than a level of outpatient treatment, but it's lower than a hospital level of care. And that's an important gap in services that we have today. And most of those people can be treated there. And then it's also needing people to get that wraparound support post-crisis to prevent future crises. And you can see the goal of this is to really decrease emergency department and inpatient hospitalization and jail use among people with mental illness. And that it starts with a phone triage, because that is the least restrictive and least costly piece. And we do have suicide prevention and crisis services in our community that acts as a crisis line for people. So just wanted to make you aware of that model that's out there that Office of Mental Health really is promoting now. And so the next slide, I thought it'd be helpful for you to see some of our current data. This is data from August 1st to October 31st. We've revamped, we went from literally a log that you couldn't pull any data from in the last few months to actually creating a system where we can pull data that can be useful to us. And of course, as soon as you start to pull data, you find all the things you wish you had asked. And so we also found some mistakes. So just to be transparent with you, it's not perfect, but it's a big improvement of where we've been. And there is one mistake I'll talk about actually in a couple of slides here. So what law enforcement was saying, it is true, 74% of our contacts are responded to. We had 135 crisis contacts within that 3-month period of time that was serviced to 92 different individuals. And 74% of them were responded to by phone and then triaged to determine if we needed to see the person in person or if we needed to, or if we could just do a good response by phone. I'll let you know the time frame we're seeing that we're most utilized is maybe surprising. It's actually during daytime hours. I think it's Mondays and Thursdays are our biggest days. So what you see of those ones we're responding to in person, we actually have people who just walk in off the street into our clinic in a state of crisis. So that was about 13% of the mobile crisis team's work that was in person. And then there were 18 individuals, or 18 that came into the mental health clinic. And then there were 17 individuals that we co-responded with law enforcement in the community during the last 3 months. So next slide. So how do people get a hold of the mobile crisis team? So this was surprising to me. The model was actually built that people would get in contact with the mobile crisis team through the Suicide Prevention and Crisis Services. And after hours, they provide our triage. And if someone needs more intensive services, they reach out to us. And 9% of our calls to mobile crisis team are actually coming from them. So if they get a call that they say this is pretty serious and needs a stronger intervention, they send that call over to us. About 23% of our calls are coming from law enforcement agencies, but a whopping 68% are people contacting our front desk at the department and getting a hold of us directly that way. So I wanted to sort of look at who are the people contacting us directly at the mental health department, and the next slide really breaks that down. And you'll see that there are a number of different groups. The first I wanted to point out is there are outreach workers like the LEAD program and Family and Children's program. When they're in a situation where they think it needs a more robust clinical response and maybe emergency, about 10% of the time, they're the people reaching out to us. And then about 16% of the time, it's a community member. That could be a family member, it could be a neighbor, it could be a business owner. That's really who falls into that category. You'll see we even have people who are clients themselves who reach out to us. A lot of times people can experience ambivalence. They may be really thinking about dying by suicide and having an attempt, and that frightens them at the same time. And they reach out directly on their own for support. Then we have a larger group that sort of makes up this other of calls, and those are a lot of different agencies in our community, like care managers, Ithaca Neighborhood Housing, Department of Social Services, the Health Department. Lakeview is one of those agencies that works with people with severe mental illness in our community. They often reach out to us, the Mental Health Association, and so forth. So I show you this to have you be aware that many, many different people are reaching out to our mobile crisis team on any given day asking for support. Now, about 50% of the time, it's actually for this 3-month period of time, it was 51% of the time, law enforcement was involved in some level of our engagement. And that could be, we reached out to law enforcement because somebody contacted us. Sort of how John was saying, for the police department, they might go into a domestic violence situation and then realize, oh, there's a mental health issue here. And then we might get these calls from people that make us aware of a mental health issue, and we realize we need additional support from law enforcement, and so that we can respond to it adequately. So it comes in all different directions. I can't really break down that information yet for you better on what do those responses look like where law enforcement is involved with us, but about 49%, and that seems to be a consistent number, are responded to without any law enforcement involvement at this time. So you can see the next slide there. So just so some information about our outcomes, 44% of people are stabilized in the community, and that's where we have a mistake. We discovered that we added an other box for our staff to fill out, and that people, rather than clicking off one of the categories, actually preferred other, and then they would write in actually how they stabilized the person in the line that was provided. So a lot of those ones that are in that 20% other category actually really should be moved over to our stabilize. It's probably more like 60% there, but we have to clean up our data a little bit, so I can give you a better analysis on that. But also in that 20% box are people who have ongoing crisis support. So it may seem like, okay, a person calls you, you respond to them, and that's that. And that's an episode of crisis support from the mobile crisis team. But there's often times when we might be talking with multiple people in the community about an individual who's having a crisis, providing support to try and really wrap services around somebody in the community that may take on several weeks in a period of time. So they're considered an ongoing client of the mobile crisis team, that we're still trying to wrap services around them to prevent that emergency from happening and stabilize them. So there's a group in there, a pretty significant group of that 20%. And another sliver of that are people that are lost to us, which is really heartbreaking. Sometimes we'll do a lot of work and find and put a plan together to support someone in the community. And before we can implement that plan, they're no longer able to be found. And you can see there, 8% of people go voluntarily to the hospital. We talk with them and work with them to find a safe way to do that. And then 27% are going by transport. Most of the time, if possible, that's with an ambulance with law enforcement support whenever we can do that safely. And those are people that the determination has been made that they really meet the criteria for an emergency and need to be further evaluated at a hospital. That tiny sliver of 1% is our crisis negotiation team. And sometimes there are calls that can come in that do have a mental health component, but they really rise to a level beyond what a mobile crisis team can do. Situation might be where individuals in imminent risk, like they're not just talking about how they're going to kill themselves. They're like maybe have a weapon in their hand to kill themselves with, or they may be jumping or something like that. And they have 2 mental health staff on their team. They have significant expertise and negotiation skills that's well beyond what our mobile crisis team has available. So for those really high risk, high emergency situations, we're really lucky to have a team like that in our community. So I just want to conclude that our mobile crisis team is a part of a much more comprehensive crisis plan that's providing a sort of a unique service to the community, and that we're very grateful for the support that we get from law enforcement, from dispatch, and from so many other community providers who reach out to us and work closely with us in trying to build a plan that will stabilize people in our community.
Thank you, Harmony. I appreciate I know, brief description of a very, very complex issue. What we heard from each of you is that the criminal justice system is asked to do a lot of work, and we need to realign the work and responsibility within the service and to ensure that we have an appropriate response for our community. We're going to go into our Q&A portion of this session. There are 4 ways that you can ask questions. One, I'm going to encourage you to go to the website through www.publicsafetyreimagining.org if you're not comfortable speaking in this forum. Another way is to use the raise your hand feature, and then we can elevate you as a panelist and you'll be allowed to speak. Another way is to put a comment in the chat, or you can also use the Q&A function. We already had an initial question, I believe, from Cynthia. And so I'm going to ask, I believe this is a question from Mike here. Cynthia asks here, she says, thank you for your time and presentation. How do you determine and who determines if the mental health crisis is due to a mental illness or due to a physical illness like a diabetic emergency? Does EMS respond as well if there's a question of mental physical distress?
That's a great question. And it really, there's two answers. So the first one would be based on how the call is received by the 911 center and the information that the caller gives them. If there's ever a question that the person, regardless of what may be initially observed by the caller is a medical emergency, most certainly EMS will be called. The protocol that we use is referred to as emergency medical dispatch. And in the examples that you gave in your question, both a diabetic emergency and a psychiatric emergency, we would use that protocol. The second way that could be determined is so for example, if we get information and we're not sure, and it's not immediately necessary that there's an EMS response, if law enforcement arrives on the scene and they do their assessment and they realize that maybe there's a medical emergency, they'll call dispatch and ask for EMS to be called. Cynthia, does that answer your question?
And Cynthia's not able to respond back,
I'm
but she
sorry.
can put a note, and that's okay, a note in the chat, but I'm assuming that Cynthia, one, thank you for being here. Cynthia will send us another note if she has, or if Cynthia has another question. How about that? She says, yes, it does. Thank you.
Great.
Good job, Michael. Thank you. I'm actually going to give Laura a chance to respond. We can elevate Laura as a panelist. We're asking for those who speak live. We try to keep our questions and responses to two to 3 minutes max, because to give other folks an opportunity to speak as well. So Laura, thank you for being here. Feel free to speak up.
Thank you, Deanna. Thank you for having me. My name is Laura Britton George. I had a mental health crisis 2 or 3 years ago in the first year of the mobile crisis team. At the time, I was actually working at Tompkins County Mental Health. So I knew that the mobile crisis team existed. Suicide prevention was after hours. They weren't available, so I called 911 and asked for the mobile crisis team. Now, I was having a panic attack. I felt like I was dying. I felt like I needed to die. I was very scared. And so when 2 officers came to my door, I was confused and asked, I'm sorry, is there anyone from the mobile crisis team I can speak to? And they said, I'm sorry, I don't know what that is. And I said, oh, well, I work there. Here's what it is. Can you call dispatch? So basically, I had an experience where I was very vulnerable, and even though the officers were professional, they did the best they could, I needed a mental health professional right then. And I wasn't able to connect with one. So my question is, I know that mental health has internal data tracking, but is there quality assurance being tested throughout the system? For instance, are we identifying how many people call with a mental health concern who are actually being connected with mobile crisis? Are we tracking what happens after? Someone actually, the next morning at work, the then deputy commissioner came into my office to ask me about what had happened last evening, because someone had called and said that I was being non-compliant the evening before and asking for special treatment. I was so embarrassed I almost threw up. So how are we tracking this throughout the larger system?
I am going to pose to let anyone here answer the question, but I also would like to note that we recognize as a whole in totality of the system that data tracking and data analysis is a point of growth, something we need to improve on. It has actually been affirmed through actually comments like yours, Laura, but also other stakeholders. And also we've heard that from other folks who are working in the system. We need to do better. We need better systems. And as a result of that, we actually have a plan recommendation that is to standardize data tracking for the reasons that you're talking about. I'm very sorry to hear your story, and I appreciate your bravery in coming into this space and sharing this in this way. If you guys have other comments, Harmony, Derek, Mike, or John, please feel free, but I just wanted to raise that, Laura, that you are raising a very salient question that we all recognize as a prominent issue that we need to work through in order to be effective.
Yeah, I can just add, and again, Laura, I'm sorry you experienced that and you went through the issues you did, and I wish you well. I can state that I know there's some truth to what you're saying as far as a lack of knowledge. When I took office 3 years ago, and before Harmony was here working with us, there was a time when I found out about the team, response team, and learned that members of my agency didn't know about it. And I don't know what agency you're talking about, but I'll admit there was a time that people in my agency didn't know that. We did reach out to mental health at the time and had a meeting and established a communication and a relationship and got to know a little bit about it. In all fairness, I think perhaps the program was somewhat relatively new at the time, and maybe it didn't make its way to the sheriff's office. So that's at least a part of a response to your question. Secondly, as far as tracking goes, most time law enforcement is involved. Like we mentioned, things are handled by way of a 941 order. that was already mentioned. And at that time, we're just trying to determine if the person is a danger to themselves or somebody else. It's a pretty broad type of understanding. The deputy that responds or the officer may not know exactly what is wrong with the person, but they think they're exhibiting behavior that makes them a danger to themselves. And at that point, we're concerned for their own safety, and that's when we take them to the hospital for a full evaluation. When we do so, we do fill out a very in-depth form with what we observed and the interaction we had with the person, what statements were made, things of that nature. And then after the fact, that form is faxed to the mental health department so they can track it however they see fit. Hopefully that answers at least part of your question.
Thank you. Thank you, Laura, for being here with us. If it's okay, Laura, we're going to go to the next, or Harmony, if you had a comment, and then we will go to the next.
Yes, I'll be
Please.
quick. And Laura, I just wanted to again express sadness really over that response. And I think we're all working to not have that happen again. That's what this whole process really is about, and how to strengthen that. So when people are experiencing a panic attack, they get somebody who can help support them with that. And like you said, I think that law enforcement does a really, really good job in responding to these situations, but having somebody with that clinical background can make a difference. A lot of those situations right now, I would hope that someone might be able to get the mobile crisis team on the phone and talk with you and give you some privacy and some space. That's how I hope it would be responded today. But I take your question seriously about the need for quality. And like Deanna said, we're in the beginning stages of that. And we've had conversations with, law enforcement, as well as how we can work together to make sure that we have good quality data in the future so that we can make sure that it's a good service for our community.
And again, I want to just clarify that the officers were professional and kind, but I would never send a teacher to do a hostage negotiation. I wouldn't send a doctor to bust a meth lab, and it's just a lot to be put on a officer's shoulders, and it's not helpful for the person who's in crisis.
Thank you, Laura. Well said. And I think everybody, you see nodding heads on here, I think everybody's in agreement with that statement. We appreciate your time. So I'm going to try to switch things up between the different types of responses here so that we have folks who are raising their hands, some folks in the chat, some folks in the Q&A, and then our tech genius behind the scene, Dominic Recchio, may have some folks who have comments on the webinar function that he'll send our way as well. I'm going to read a couple comments here. I believe there's a note from Krista, I believe. Here it says, it is hard to know sometimes what is the most helpful thing to do, but the no helpful thing to do is. As an example, a neighbor with a clear mental health issue, in parentheses, bipolar, was clearly off his meds and began to engage in illegal activity. We offered to take him to the hospital in hopes that if he got on meds, he would then discontinue the illegal activity. He continually declined our offers of help. Eventually, we called the police to report the illegal activity. Is there anything that could have been done, any kind of intervention on any mental health side that could have gotten him help sooner and curbed the illegal activity sooner? Harmony or Derek or John? And I know this is a very specific question, so you may have to know more about the circumstance, but if you have anything you'd like to share.
What I would share is that sounds like a typical kind of situation someone might call our mobile crisis team about. And when I was sharing about how some of these scenarios are ongoing, this sounds like one that might be like that. I'm not guaranteeing that we would get a better outcome than you did, because people have the right to choose to take medications and get treatment unless they're in an imminent danger situation. People do have the right to choose to get treatment. And sometimes people do not, and that can result in outcomes that we would like to not see happen, and we know it is related to their mental illness. But this might be a situation where the person could be referred to the LEAD program, or we could, try and find other wraparound support services for that person that can encourage them to make choices that would hopefully reduce the risk of some sort of legal involvement in the end. And I think we're working hard to try and offer that. So my recommendation in that situation would be that's like a situation to contact the mobile crisis team about. It's not an imminent situation at the moment, but it could build into something like that in the future.
Thank you. Thank you. I'm going to read any other comments. I'm going to read a comment here in the chat. This is from Cynthia Brock. She says, I'm a different Cynthia, but here's my question. For the economically vulnerable and for those who are unhoused, they are less likely to have access to a phone to engage with telephone assistance or call for crisis supports. Do we have a way to identify, measure, and support those without phone service?
I would take that one again. That's a really, really good question. And I think we can do more potentially about that, maybe working with libraries or different sources like that. But right now we do get, on that slide that I showed you, who reaches out to us, a lot of agencies like DSS or the outreach workers who are working with people who are in economically vulnerable situations reach out to us when they have some concerns. We also have open access hours at our clinic, so people can just walk in the door. Not only can do people, and like you saw on that one slide, people they just walk in the door when they're in a state of crisis, but they can walk in the door during our open access hours to be seen for an intake session. And so hopefully we can get them hooked up with the services they need. Not perfect. I'm sure there are some other ways we should think about how to respond, but those are the things that we're doing currently.
Thank you, Harmony. We're going to change things up just a little bit. We're going to call on a raised hand here. We're going to call on Barbara. Thank you, Barbara. You've had your hand raised. You've been very patient with us. Thank you. And then the next, we're going to get some of the Q&A questions that are in the other form. Go ahead, take it over. Thank you, Barbara.
Yeah, thank you very much. I've been for a long time interested in the question of wraparound services being looked at much more expansively. And I'm wondering if all of you don't see a potential. I thought that it was opened up in Ithaca during when Decarcerate Tompkins was at its most effective and had some really wonderful dialogue around, what would be an effective way of working on decarceration issues. And it seems to me that there was a lot of success around that question. And I'm wondering why we can't export that kind of thinking to mental health crises, especially those crises that end up, implicating law enforcement. In other words, the issue of really looking at mental health recidivism and the correlation with poverty, early abuse, continual return to the criminal justice system. I mean, I would like to see slides that show that sort of data so that we're looking at the question of recidivism in a really broad social way. And we start having a lot of the public advocating, for instance, for fairer taxation, the big issues to get more money in the system to support the creation of jobs or the creation of guaranteed income, all of the supports that we know support mental health. And the only other thing I want to add, I'm sorry, is the Kirby Edmonds connection, that he was so valued. And in all the tributes to him, I wanted to hear more emphasis on the ideas that he kept pounding away at that have still not been enacted. And those were identification of the most vulnerable people and this expansive notion of wraparound services directed to the very most vulnerable people. And then thinking of recidivism in terms of difficulty in school for children, thinking of recidivism, more mental health crises. You get what I mean, right? I'll stop talking. I'm sorry.
No, thank you, Barbara. I appreciate the energy and enthusiasm. This is exactly what we need. Well, you know what? I have a challenge for you, Barbara. I want to put all of those ideas at www.publicsafetyreimagined.org. Everything that you just said, I want you to put it on the website. And I really appreciate you doing that. And so, no, thank you. And also, we want you to keep coming to the forums. We want you to keep lifting up the ideas. From what I've heard, I didn't have the honor of meeting Kirby Edmonds, but from every person I've met, specifically working with the community leaders of color, Kirby was an amazing human being, and his legacy continues. And so, Barbara, put those comments again on the website, and we will be here and look forward to having you raise your hand at the next one. If we can go to the next person here. Thank you, Barbara. I'm going to call on a couple people who are in the Q&A section. This is a question from Reba. Is a 945 used only for involuntary transport, or is it also used for voluntary transports? It's in the question. It says, is a 945 used only for involuntary transports, or is it this also used for voluntary transports?
It's only used for involuntary.
Thank you. Then I'm also Ed had a question as well. I have credit reports of much disarray and controversy at SPCS over recent months. Has that affected ERS? Now, can we spell out these acronyms, good people? Can we spell them out? Derek, do you know what that means? I see you laughing. Does anybody? And also, Ed, I'm not, if you can spell those things out, if people know what those things stand for. Go ahead. Derek, did you have a comment?
No,
Oh, you did? Okay.
Because I didn't know.
Okay, Laura, just
I do. It's suicide
go ahead.
prevention. It's suicide prevention crisis services, and I think asking if that has impacted emergency response. I am not aware of an impact in the emergency response.
Sure. So I not heard it as a response as ERS. So in that way, but the SPCS I was familiar with. One thing that I think will be important to lift here, though, we have a colleague here who's actually doing yeoman's work, Beth Harrington. There will be a transition soon to a 988 number. And so I think I'd be remiss when we're talking about mental health and suicide mental health response in this space. And so we will be asking Beth at some point, if it's okay, Beth, I know I'm just saying your name here on the forum here, to have you come and talk about that transition and what that will look like, because that's going to be a powerful tool as we move forward. I think the next question from Laura has been answered. Then Camille, we have a question from Camille Tishner. How does law enforcement decide that a person is experiencing a mental health crisis? Is there specific criteria or experience or something else? I think that might be a Michael Stitley or Derek question.
Yeah, I mean, I can say we put considerable effort in providing adequate training to our deputies and officers in that field and trying to recognize signs of mental illness. Now, of course, like we've all agree upon, they're not clinicians, but they have become very adept to identifying people that suffer from a mental illness and or intoxication for that matter. Was there more to that question, Deanna? I'm sorry. Was that, I thought there was another part.
Actually, it's been closed. Let me see. Answer just a second. Nope, there's not this time. Also, I just want to encourage folks as we get towards the end of the questions, if you would like to ask a question, you can again do that 4 ways. Put it on the website, www.publicsafetyreimagined.org. Put your ideas there. Also, put your questions in the chat here or in the Q&A, or raise your hand if you would like to speak as we continue the conversation.
Yeah, if I could just, I'm sorry, if I could add, Deanna, to her question. Like I stated before, I mean, law enforcement, when they get to the point where we're interacting with somebody possibly experiencing an issue with mental illness, again, we're only looking at that point if they're a danger to themselves. We come across a lot of people that we know are suffering from mental illness, yet they don't pose a risk to themselves or to anybody else. And that's where some of those wraparound services and referrals come in handy for us. If we do feel they are a danger to themselves, then we use a 941 to take them to the hospital. And that's where they're properly evaluated by a professional to determine what their issue is. Hopefully that helps.
Thank you. I think that was Camille's question. Going to pivot to a comment that's in the chat from Fred Balfour from Dryden. Fred says, I'm impressed with the process as laid out today for emergency response. I'm really impressed by the described interaction across multiple organizations. I'm curious about ongoing funding for emergency response. Is the current funding adequate for our county? Do we have streams of funding into the future that will make it adequate? And can you give a high-level breakout of the portion funded locally, from state, and from federal? And I'm not going to put anybody on the spot because I'm fairly confident we don't have that information right in front of us. However, Fred, you asked a great question in terms of transparency and how we use funding. And so we have provided some of that information previously at the very, very beginning of the Reimagining public safety process. If you go to I can put that in the chat, where the original site where it's housed at Tompkins County, and I can have Dominic put that there. There was a presentation that the sheriff and some others, some folks from the mental department did about a year ago that has that information in it. It has actually a budget breakdown of the expenses that are and where they occur. And so we'll get that to you, Fred. And so again, I don't want to, someone has that answer who's a genius that can pull that right out, or I can direct them to the source where that information is.
Yeah, I can't provide a response to that high level of a question, but I can say, in the sheriff's office budget alone, we've been very fortunate over the years to get a lot of support from the county for at least a part of the issues we experience now. It wasn't all that long ago that we were provided a position of a forensic counselor inside our jail to help with our inmate population as they come in to identify mental illness concerns and do a soft handoff of those people to whoever they need to be referred to when they exit the jail, things of that nature. We also have had funding for our crisis negotiation team that helps negotiate incidences oftentimes with people suffering from mental illness, that has become a component of our specialized response team in responding to volatile situations where they're needed. They go hand in hand with them. So just speaking of the small part of the sheriff's office, we have received some funding to help with situations like that. And that's just a couple really, really good examples.
Thank you. And we'll get that information again to you, Fred. You asked a great question, and that's something that we do have available to us. Thank you, Dominic. There is the information. There's some information there that has some breakdowns of funding. Dominic is always there for us. We appreciate that. I'd also we acknowledge Susie Cook. If we could elevate Susie. Susie has a question, and Susie has been a critical part of our criminal justice system for a while. So Susie, feel free with your comment or ask your questions. Thank you.
Okay, thanks. Just a quick question. Are we anticipating like an increase in activity at the CMC psych unit if there are are we anticipating more 941 trips to the unit? If we are, is that booted up? Because I have juveniles that go there all the time. Actually, this summer, one actually sat in the emergency room for days while they were looking for a residential bed. There's definitely not enough residential beds. My pins and JDs, and the state is making it harder and harder to place kids that actually need residential treatment. So is that CMC psych unit component going to be booted up to work with us for this?
Anna, is it okay if I respond to this?
Of course. I was watching you take your hand off of the unmute yourself, so feel free. Yes.
Susie, it is really challenging right now with children's services, right? There's not enough, beds. There's been cuts in residential beds for kids, both in the OMH and OCFS, Office of Children and Family Services and Office of Mental Health world. And I want to make you aware that there is going to be a system of care meeting planning forum that's going to be happening in January and February to look at where our gaps in services for youth are, so that we can try as a locally to find some solutions to those problems. And we just received a very small grant, about $25,000 today, in order to help us fund a grant writer to help us hopefully look at some braided funding solutions, because these are challenges not just in our community but across the state. There's a significant reduction in beds for youth. And we just know kids are really facing a lot of crisis situations. So we're trying to look at some potential local solutions to that as well.
Okay, that's good news. The other quick question I had was, because my other hat is like with the victims, my office is in a more prosecutorial presentment agency capacity, but when you have a mental health crisis and it adds the added component of somebody breaking the law, they're assaulting somebody, they're trashing people's property, they're robbing somebody. I just wanted to make sure that when there is that component, the victim retains their voice, not that someone goes and there's mental health work being done, but that there's also the law enforcement's for the victims, they're understanding that going for mental health treatment does not negate their ability to follow through with being made whole or seeing how things are, shaking out or helping them be made whole. I know, I would assume for the mental health calls with weapons, law enforcement's always going to be going. And just that the victims understand that they're not lost in the process.
Thank you. I think you raise a powerful point, and I think that it's always important to raise those who are most vulnerable. In this case, you're talking about the victims, and so I think in terms of reimagining public safety, when we think about this work, accountability is a part of this, and we all, there could be criminal activity and there's not criminal activity. How do we respond? And so I think that is on a case-by-case basis. And I think it's really important, again, what you said. And I think that's at the heart of what we're trying to have a better understanding of as we think about what the alternative response is, knowing that there are consequences for actions irrespective of what of the circumstances.
We did a lot of work on the restorative justice concept, and I just find that very powerful.
Sure.
So
thank you. We have a couple more questions here. It's from an anonymous attendee here. Considering the current response model, what do panelists think can be done to improve the overall response? I'm going to start with John. You know why? Because we haven't heard from you in a little bit. So John, will you answer that question?
Sure. I don't have all the answers, but, from my perspective, I can tell you what I think would be helpful. Some of the issues that we run into as law enforcement responding to and assisting with people in mental health crisis is that there's just a lack of mental health treatment facilities. And as we just heard a little bit about beds for youth, but I think that also carries over for adults. So particularly when we, come across somebody that's in crisis and we, bring them to the hospital, which is really our only option locally for mental health evaluations. We'll bring them there, and particularly, they go in through the emergency room generally, which if the emergency room is busy, we've had oftentimes where officers are, having to wait in the waiting room or just kind of waiting for a bed to be available or room to be available. CMC does, what they can, but they have very limited availability to deal with these. And oftentimes what we'll find is we'll bring people up there that are in these states of crisis, but they're very familiar with the system. So they'll, be asked a series of questions that they probably have been asked many times before. They already know the answers that need to be given to be released. They provide those answers and then they're right back out. And oftentimes the sheriff's department is then dealing with these people between the hospital and the city, within, a matter of a half an hour or, potentially an hour. And then it's just this revolving door where there's really not a great place that can help these people and give them the treatment and care they need. And so, the other systems that are available, such as law enforcement in the emergency room, they try to do what they can, but they're really not set for that. There just isn't enough of an actual resource available. And I also think that having, trained counselors or mental health professionals that, have a high degree of training in crisis negotiations potentially, or, mental health, social work, that could actually respond out to the scene, on a 24-hour basis that could, intervene, or we could deal with the criminal aspect if there was one. We could get get them linked up with that service, and then law enforcement could then leave, and there would be like a continuation of care, and it would be, a service that has access to, mental health records, so that they could, be aware of history with the person, and ensure like a continuation or continuum of care throughout, with follow-ups later by whatever resources available. But I think those two things, we need more resources in treatment centers and places that can handle the people that are in crisis, and we need a 24-hour response to assist law enforcement.
Thank you. And this is a question I think that everybody on this screen needs to answer. Okay, I'm gonna go to Derek. Raise the question again. Considering the current model, what do the panelists think can be done to improve the overall response? This is questions just for you. Go ahead, Derek, take it away.
Sure, thanks, Deanna. Yeah, I agree with what the chief mentioned as well. It's no fun thing or something that law enforcement looks forward to, is responding to people in crisis from a mental health perspective. We understand that there are better services and response models available than we can currently provide. Again, unfortunately, it's just one of those things that we have always been to go to over the decades because we have always been there. I do think law enforcement does currently a really good job with these situations, handling them with what they're dealt with. They oftentimes, like I think Harmony mentioned, get to know these people. They interact with them frequently. But I'm a component or a proponent of the co-response model. I'd really like to see an opportunity for law enforcement to partner with mental health better from the response standpoint. If that means, maybe being in the same vehicle together, having people from mental health that will come to a shift briefing and partner with a deputy and go out together. I just think that kind of gives the best of both worlds type of response. Law enforcement can protect the scene if we need to, if there's a situation that becomes violent. But we also have the mental health trained professional there to provide a better interaction and response and to feed off of each other. That's what I would like to see, but I do understand that that's only one option and probably a variety of options that we could come up with. I just know at this point I'm open to all considerations, and at the end of the day, we just want to do everything as best as we can.
Thank you. Harmony or Michael? You're both going to get to go, I promise.
Sure. So I think it's a fantastic question, frankly. And I completely agree with a comment that the chief made as far as 24-hour services. I think that would be fantastic. And I also like the model that the sheriff described, the dual response model. I think that would be wonderful. So if we could have that 24 hours a day, I think it's the best of both worlds. But specifically to the 911 center, I would like to see some enhanced training for the 911 operators so that we can do a really good job at assessing these calls and making sure that we get the proper resources there. I think there's some opportunity, maybe even having some specialists in the center 24 hours a day. So maybe that they're immediately available to help. And so we can transfer the call to Harmony's team. So I think there's a lot of opportunity, but I think what I'm really most excited about is if you just look at this group here tonight and the enthusiasm that we all have to try to make it better for our community, I think continuing to collaborate, we're going to find the right model for us. Thank you.
Harmony?
So it's funny. I like the co-response model as well. I think we're all kind of in agreement. That's a model that can make sense for these more intense kind of calls. But there's some other things that I think would really be helpful as well. I really liked the comments about wraparound services. We have some of those services now. I'd like to see them strengthened and better coordinated. I think we have a lot of services in our community, but having them in a better coordinated so that we know, did that person just get discharged from the hospital? We know statistically about 50% of people don't go to their first appointment in outpatient. How do we fix that? How do we provide warmer handoffs? How do we maybe have more peer support services that people can get connected with someone personally so that we have a greater likelihood of people actually getting connected with the services they need. I think that's a huge part of it. Talked a little bit about Crisis Stabilization Center. Our hope is to have one in our community, at least for people with co-occurring disorders. Hopefully in 2023, that's going to make a significant difference because it's a lower level of care. I think we can look at some other levels of care that we don't have in our community. We don't have a lot of crisis response, crisis respite. And we don't have like a living room model where people have more places they can go and maybe just get some of that kind of personalized support they need. So there are other models we can build. I think we need to expand our outreach worker program. We have some really good models for that. It's really like, right, you got to address this from a prevention perspective and get people before their needs get so high that you need a co-response from the mental health department and law enforcement or whoever that co-response team would look like. And then also, how do we support people who have had a significant crisis so that we don't have a relapse and a crisis again? So both angles that way. And some of these things are actually not high cost things. They're more about being better organized. So those are places I'm hoping to start and over the next few months, year.
Thank you. And I'm going to ask a question here that's not on here because I think, you know, coming from the community perspective, and my role is as Chief Equity Diversity Officer to look out for vulnerable people, vulnerable communities. So, you know, if we have a history of distrust, you know, in certain services or just, you know, in government in general, how do we anticipate we'll be able to bridge the gap in some of these issues related to trust? And I think that those things, because I think a lot of the ideas are, you know, I think there's some agreement and we've heard different things, but how do we think we can get the community there? Does that make sense? Because Executive Order 203 came as a result of the murder of George Floyd, you know, and so there's lots of things in terms of history, in terms of systemic inequities. And so looking at disproportionate minority contact, are there things that we think we can do to build that trust gap to address some of these things? And anybody can take that question.
I'll answer that. That's why I really like peer support services and peer models and things like that. You have to have people with lived expertise bring a different lens to a situation. And I think you really need to make sure that you're getting diverse voices in the room and you're getting voices of people who help you design programs. I know there's an agency in town that has a committee of peer support of peer people who help them design their programs. Like they're going to look at the language they use. They're going to look at how those services are going to be delivered through that lens. And I think that lens is incredibly important from a diverse perspective and from a lived experience perspective.
Thank you. Derek or John or Mike, you want to speak to that at all?
Go ahead, Mike.
No, okay, sure.
Yeah, I was just going to say that sounds like a whole different presentation. You know, that's a big issue that obviously we got to work on in all aspects of our responses, not just mental health. So I don't know if I have any specific thing to say in response to that as far as responding to mental health crises at this time.
So, and I would just frame it against, so for example, people of color could be having a mental health, crisis issue. And so if we know that there's already this crisis and there's this layer of distrust, how do we get there with those people? Does that make more clear, Derek? No,
you're right. It does. And I think that comes more into play with what we talked about before, that a lot of our responses that end up being mental health related is criminal activity possibly, and they're reported that way. And then we discover it's a mental health issue that's a component of that. So I say, again, that's more of a conversation for our overall response to just about everything. When it comes to mental health, unfortunately, law enforcement is simply just responding to when we're notified of such a thing. It's not something that we're out actively like enforcing, like a different type of crime or something like that. I know I'm not really answering your question, but I'm not sure I have an answer for it at this point with this particular topic.
So that's okay. And again, the question is not to put anybody on the spot, but just when we talk about centering vulnerable folks, and everybody knows when they see Chief Equity Diversity Office, I'm gonna ask about this topic. And so because that's why I'm here. And so John, did you have anything you'd like to add, or Michael?
I think the sheriff hit on it. I mean, really, it's, potentially the co-response would be another way to try to, where it's not just law enforcement coming in an enforcement manner. We could accompany mental health and then, link them with the services, and then we, would just be a partner in that. And then we would continue to move on with our, typical law enforcement duties.
Thank you. And again, I'm just thinking about, I think Laura made a excellent comment earlier. She was talking about the relationship to people, and I was just hoping to circle back around that in terms of our minoritized groups. And then but we know that Derek and John, this won't be your last time with us. I'm gonna come and ask you that question again next month. I promise I'll be here. Mike, you have anything you'd like to add?
Yeah, I think more broadly speaking, I think trust is a result of developing relationships. So I think the more that we can do to develop relationships with the community, such as these types of forums, I think will help build that trust. So I think being maybe more available, doing town halls where people can come and ask us questions and they know that we're approachable. I think that's where we start to build the trust. And then as we are approached with more sensitive topics, I think our voice will, it will be heard differently if they believe that there's a relationship there and they trust us.
Thank you. I appreciate it. And we'll keep raising that, because the executive order, centers the experiences of Black and Brown folks, also knowing that a part of this, we're also looking at other minoritized groups and also the greater community. We want to, this response to assist the majority population as well, but just wanted to raise that within the context of thinking about this. Barbara also, I believe, put a note in here as well. Says, thank you all so much. I am finding this forum so heartening. What has been confirmed is precisely what activists have been calling for forever. We need a well-funded co-response model, and we need strong advocacy for mental health beds and care as well. And for instance, the long-term work, getting guaranteed income and adequate housing for returnees to the community after mental health services. So thank you, Barbara. We appreciate that comment. Beth, also, I believe this is Beth Harrington, also placed a comment here. So maybe something that might be doable right now is looking at follow-up approaches, follow-up contact by whatever methods has been shown to decrease recurrences. That Harmony is talking about one resource that might be used for this. And so thank you, Beth, for raising that comment. Do we have, I was going to check to see if we have any raised hands. I don't think that we do right now. We have 12 wonderful, fast minutes until we wrap this up. And so thank you guys for your continued engagement. Again, at almost 5:30 right before dinner. And I know that this forum is standing between you and going home. And so again, thank you for being here. We have a couple more questions in the Q&A here that we want to lift. It says, I think Reba asked this question: are health insurance costs an issue for people who need to be transported via ambulance? If so, what resources are available for them? This would primarily impact the underinsured.
It is my understanding that that does impact people. The cost of the ambulance can impact people. We work with people when they're in a crisis situation to try and find a solution. Sometimes if a person can be safely transported by a friend or someone else, or sometimes law enforcement does make more sense in a situation where if a person is really concerned about the costs that they might incur from that. And it is a barrier to, we know that lack of health insurance is a barrier to healthcare. So it does play a role sometimes.
Go ahead.
Yeah. And I can add, there are times where when law enforcement responds to somebody in crisis and we feel they need to go to the hospital for evaluation, that oftentimes does come up. We don't prefer to do it. We prefer people to ride in the ambulance if possible, but we have made exceptions for that and transported people up ourselves. And sometimes either way makes a difference with the person. Sometimes they'll say, well, I'll go and have the evaluation, but I don't want to be in the back of a patrol car. Or they may say, I don't want to go in the ambulance. And we try to accommodate them the best we can to alleviate any unnecessary concerns. And they're already dealing with enough at that point. So we do try to make exceptions to help with that.
John, did you want to add to that?
Yeah,
Okay.
Just in addition to that, I know that, we've had some recent incidents where, the people that were in crisis had specific requests or, concerns about getting treatment because they didn't want to ride in an ambulance. And we've gone so far as to bring up unmarked cars and have them transported in unmarked cars just to, gain their support and get them, their buy-in to getting some help and treatment and trying to alleviate any, stress that they were experiencing due to just the transport.
Thank you. Mike, anything to add there? Probably not, but just in case you do. Okay, thank you. Just a couple more questions we have here. And again, feel free if you are jumped in. I know we have a person we have a call-in listener as well. If you want to raise your hand, if you'd like to speak, feel free to do so. Raise your hand and Dominic will elevate you as a panelist. You can continue to ask questions here in the question and answer or put your comments in the chat. We've had some really great questions as we wrap up. I feel energized by the comments and questions on this evening and the energy and the thoughtful responses that we received. So I think there are just Camille asked the question, do we know why beds for youth have been cut? And we may not know the answer to that, but she was just asking if we know why.
Could you repeat that, Deanna? I didn't quite.
Do we know why beds for youth have been cut? It's okay.
I can just give you a very rough description of that. New York State is really hoping they spent a lot of effort into developing community-based levels of care. And the philosophy had been that by establishing these more robust community-based programs, that there would be less need for these higher end levels of care. Unfortunately, what has happened is that those lower levels of community-based services, their home and community-based services and children and family treatment and support services, actually haven't taken off to the level they thought. It has a lot to do with the funding levels to those programs. Providers who are going to offer those services actually couldn't afford. The rates were not high enough to cover their true costs to provide those services. So what we've ended up in is a little bit of a mess. The assumption had been we'd have these really great community services that make a lot of sense. However, we haven't had the providers pick up those services and start to provide them at the level we need in our communities to make a difference, so we don't need those higher end beds. The state is well aware of that, and they're looking at ways to change that and get more of these community-based services active in communities.
Thank you. We have another question from anonymous attendees. Says, thank you all for being here. First question is, what percentage of mental health crisis calls involve deadly weapons? And the second question is, what percentage of mental health calls result in arrest? And we may not know that answer, but we don't know that right now, but maybe something that I'm not sure even we know we have a process for tracking that. Is that something we could find out?
No, I don't think with our record management system that law enforcement currently has, that's possible to track at this time. As I mentioned before, a lot of times a call will come in as one thing, and then when we respond, we end up it's another. Now, dispatch does enter a code based on what they receive the call as, and that law enforcement can switch codes as well when they get to the call and determine a better fit for what that incident actually is. But there's not a way really just to differentiate the two currently, so it's impossible to say. As far as the question with weapons, we don't track that either. The majority of mental health response calls don't have weapon involvement, but some of them do. What that number would be, I have no way of saying.
Thank you. We have a little less than 5 minutes left. We just have a couple more questions and we can get to them. We may not be able to make it to all of them. We have you as professionals in the field seem to know what types of things would help. How do we get there and what are the hurdles? And I think that you all alluded to that answers to that question earlier. Is there anything you would like to add to that response? And if not, that's okay, but just wanted to raise that question as it is in the chat. No more comments? That's okay if you don't.
I mean, I think at this point, we just have to identify the model as a community we want to head towards and then seek the funding to make that happen. I think it's as simple as that. A lot of these models obviously are quite expensive. So there'll be a lot of discussion around this topic, but I think we start with what we're doing here, talking about different response mechanisms, ideas, and coming up with an approach that fits our community the best, and then taking the next step to see how we make that happen and supporting that financially.
Thank you. Anybody else want to add to that? Okay. Two final questions here we have here. We all acknowledge there's a shortage of residential beds. Why can't we invite the creation of a residential facility here in Tompkins County? It says, how do we make that happen? And you may not know the answer to that, but I think we can also posit that, right? I see everybody smiling here. Susie, we appreciate the show-stopping question here. Put everybody on pause. Does anybody want to take a stab at that? If not,
I would
raise that.
I can answer. I would say that the state really is trying to get out of, if it was specifically about children, but also adults, like we know that people, I've spent most of my career working in residential settings for children and youth, and we want to serve people in our communities. We don't want to pull them out of our communities. So we need to create robust community supports that meet the needs of kids and be more preventive in nature in those responses, so that children and youth don't leave their communities. The same is true for hospitalization, right? For people, adults, we're trying to create robust models in our communities so people can be community members and they don't need to be taken out of their communities to get the service they need unless absolutely necessary. And finding that right number, that amount, that is a challenge. And I know that we definitely need, to figure out those community supports and what they need to look like.
Thank you. The last question in the chat, the one from Laura George can be closed out because she actually spoke, I think asked that question earlier. This is the last question from an anonymous attendee. It says, one of the big barriers to healing in the community is an inability of the PBA, I believe that stands for Police Benevolent Association, to admit that there is a problem in local police culture. What can departments do to ensure that officers understand the issue, participate in internal culture change, and aren't hiding their heads in the sand?
I can't speak to the PBA, obviously, but for myself in the sheriff's office, I ran for sheriff on the platform of creating a sheriff's office that serves all people. And I think the best way to make that happen for any law enforcement agency is the development of appropriate policies. I believe strong internal policies is what drives culture within any agency. Not only does it drive the culture, it does so by establishing what is expected of employees of the sheriff's office by me. And it also provides that mechanism to provide accountability when something does go wrong or people aren't meeting expectations. So I think it's a gamut of three things. Proper to make a good police department is our hiring practices, what we go through to hire the best people possible, policy development internally to drive culture and hold people accountable, and then the ability to, in the decision-making process, to actually hold people accountable when you need to. That I found has been very successful for me, I feel, at the sheriff's office. And I think that's the best approach for a quick change of any culture.
Thank you, Derek. I appreciate it. John, we'll give you a chance to respond since you guys are separate departments.
Sure. Yeah, I can't speak for the PBA either. It's a labor organization. They don't represent the department. They represent the labor rights of and manage in negotiations of those rights with the department of the city. But as far as how do we manage officers and the response and how they interact with the public, certainly through accountability and with policies and supervision. We also have right on our website, we accept any complaints that people make. Oftentimes we'll get anonymous tips, or we can get complaints through the community police board, which we investigate any and all complaints that come in, regardless of the method that we receive them in, for that. But I also think that, every day, there's examples of the officers out there in the community doing great work, de-escalating situations that are extremely volatile, and people that, are experiencing these mental health crisis situations. And despite the fact that, we do try to train them, to a high level, that they're not clinicians. And, I think that there's many examples where officers are setting a great example and doing a great work on a daily basis.
Thank you. That concludes our town hall this evening. I'd like to thank again my colleagues who come here, and Harmony, who is our, again, Deputy Commissioner for Mental Health, Derek Osborne, who is the Sheriff for Tompkins County, and then also Michael Steitley, who is the Department of Emergency Response Director, and then John Joly, who serves as the interim police chief for the City of Ithaca Police Department. Again, as we wrap up, again, this public safety process belongs to all of us. Executive Order 203 centers Black and Brown folks, but specifically, it's a responsibility of all of us to keep each other safe, because this community belongs to all of us. And I think it's imperative that we all think about each other from a collective space where we are our brother's keeper. One of the things, again, that we've asked you to do is to go on the Public Safety Reimagine website, which again is www.publicsafetyreimagine, and we look forward to you sharing your ideas. This alternative response kickoff discussion will be one of many discussions that will happen over the next year. You'll be hearing from the sheriff, you'll be hearing from the IPD, you'll be hearing from the mental health commissioner, you'll be hearing from Department of Emergency Response. All of these are core functions of the work that we do. Also, we'll be hearing from 988 folks. We're also hearing from our community outreach worker. This service, again, and this problem is a huge problem that belongs to all of us, and it's all of our responsibility to work through it. So we, again, some of the questions that we're seeking your ideas on are here in these 3 questions. We thank you for your time and energy and attention to Reimagining Public Safety Collaborative, and we look forward to seeing you next time. Have a good evening. Thank you again.